Welcome to the second workshop, Best Practices in HIV Prevention and Treatment. My name is Gina McGowan. I'm with the Ministry of Health. So I'm just going to introduce the three presenters for this afternoon. Throw my papers here. A couple of things. What we're going to do is just have them come up to give their presentations. We'll do questions after. And they'll all sit up here at the end, and I'm going to be taking some notes on either side here. This workshop is being videotaped, so just to make sure if you've got questions, we can do it one of two ways. Either come up to the mic, or if it's more of an informal chat throwing out questions, we just want to make sure that whoever's answering just repeats the question so that everybody can hear. So first off, we have Dr. Rolando Barrios. Dr. Barrios is Senior Medical Director, Vancouver Coastal Health, and Assistant Director at the BC Centre for Excellence in HIV/AIDS. He's also the Principal Investigator of the Pharmacovigilance Program and Co-Chair of the Therapeutics Guidelines Committee at the BCCFE. In this capacity, Dr. Barrios leads important programs in the areas of patient safety, pharmacovigilance, and continuous quality improvement. After that, we'll have Dr. Deborah Money. Dr. Money is a professor at the University of British Columbia in the Department of Obstetrics and Gynecology, Medicine, and the School of Population and Public Health, located at the BC Women's Hospital in Vancouver, and is a subspecialist in reproductive infectious diseases. She has developed a clinical and research program in reproductive infectious diseases with research focused on HIV and other viral infections in pregnancy, HPV, and the HPV vaccine in the prevention of cervical cancer. She is the immediate past president of the Infectious Disease Society of Obstetrics and Gynecology. And finally, we will have Dr. Richard Lester. Dr. Lester is the medical head of STI HIV services at the BC Centre for Disease Control and assistant clinical professor in the Division of Infectious Diseases at UBC. He oversees clinical and public health STI and HIV programs in the Provincial Health Services Authority and is an HIV consultant on communications technology and engagement into care in the Canadian, US, and Chinese governments, World Health Organization, the United Nations, and various international research programs. So Dr. Barrios, if you'd like to come up.
Thank you very much. We'll wait to upload the slides, but while we do that, I'd like to thank the organizers for asking me to be here. I can see some familiar faces. I'm sure they will help me to answer some questions after all, because you've been part of this collaborative that I will be speaking to. So I've been asked in this session over the next 20 minutes or so to just go over very quickly at a high level in terms of the what we have done on the Stop HIV/AIDS collaborative and how we evolve into the Quality Improvement Network. I hope to accomplish today is describe an improvement approach to facilitate change and improve patient care and outcomes, to understand the collective impact of the collaborative on system and patient outcomes, and locate additional resources based on interest. This was the three main objectives of the collaborative, and I would like to maybe step back a little bit and just explain how this came about. And this really came from my interest in quality improvement and the fact that we know a lot of the science that is out there in regards to what do we need to do, when to start treatment, what to use for treatment, and so on, and when the treatment success is actually success, and yet there were significant gaps on that, and Julio showed some of that in the cascade of care, and that cascade of care is really parallel to the continuum of care, from diagnosis to linkage to retention to initiation of therapy and becoming virologically suppressed. So let me ask you a question. What do you already know about the collaborative or the HIV Quality Improvement Network? Anyone might want to venture? Okay, so I think there are probably a few who want to say, and they'll probably say too much. So what we knew when we began this journey, we knew that treatment is good for the individual, It's also good for the population as it saves lives and it saves the money to the system. And this has already been explained, so I'm not going to spend a lot of time, but this is the science behind it. So we knew that treatment is good for individual, it's good for the population, and save money. So the question is, what are we doing to implement this and take advantage of these three known facts? So we also knew that there was an effective chronic disease management model that produces better patient care and outcomes. So this has been talked about, it has been used in the past in many other diseases, particularly diabetes and CHF and COPD and others. And back in 2003, 2004, it was actually tested at the HIV clinic at St. Paul's, and later on at the Vancouver Native Health Clinic in the downtown east side of Vancouver, and more recently at the Central Interior Native Health Clinic in Prince George, with the same results, meaning significant improvements in the quality of care and the outcomes of individuals that were being cared for in those facilities. So the logic was, if it works in these three settings, why not to apply it widely into our system? I'm not going to explain the model of care, but is based on health system redesign, interactions with community, and moving practices from a reactive approach to the condition to a more proactive approach. In other words, why wait until the patient with HIV, who is known to us, go to hospital with PCP? So we need to be more proactive. We know that if they don't start therapy, they inevitably will end in a hospital or death. We also knew that great ideas and best practices were isolated in areas throughout BC. We knew that there were people doing a very good job in different areas, but those were staying in those areas. They were not coming, they were not being shared, and they were not being spread across the province, which was an important thing to do. And then that issue of the diffusion and adoption of best practices, we knew that it doesn't occur spontaneously. As much as the science tells us that 96% that antiretroviral therapy reduces 96% of transmission among serodiscordant couples, it takes years and years and years before actually that intervention becomes available. And that's part of the history, where you go back to review the treaty on scurvy back in the ages, where it was discovered that citrics were useful for that. It took about 195 years before the Army actually adopted it as a formal policy. And most recently, we've seen the issue with H. pylori and how it took about 10 years to be adopted and recognized as a cause of ulcers, and actually that there was treatment available for it. So it takes many years before we can actually do that. So it doesn't happen if we don't actually push it for that change. So the Stop HIV/AIDS Collaborative then began to close the gap between what we knew, or what we know as a science, and what we do. So that gap between science and practice. And the collaborative methodology is a structure for learning and action that aligns healthcare providers in a common aim. So we all are looking at the same aim. We need some focus, so all our energy and efforts are directed towards that. And we also share a measuring system that makes us accountable in terms of the changes that we're introducing, but also help us to monitor whether we in fact are making the changes that the intended changes that we wanted to do, or we're coming with unintended consequences. And it's usually an incremental system change that looks at testing at a small scale before you spread that change across your practice or the system. This is the model. It's a bit busy, but just to show you that this is a methodology that has been used in the past and is coming out of the Institute of Healthcare Improvement, and starts by selecting a topic. And just let me pause here for a minute, because when we started, we knew that there was a high proportion of individuals who were HIV positive were unaware of their status. And so we were being pressed to do more testing and increase or try to find those individuals. But at the same time, we knew that there were significant numbers of individuals who were known to our system, who were already infected, who were not benefiting from the therapy in this case. And therefore, through some consultation, we decided to start by focusing on engagement and treatment. And this with also the idea of increasing capacity, so when we scale up testing, we will already have a capacity to take those patients into care. And this is an important issue because finding that someone is positive is not enough. Is finding that it's positive, but also offering that individual the available interventions that will benefit their health is what is really relevant. So we started with selecting a topic, and we focus on re-engagement, and then we engage our partners, which were the health authorities. We started with a pilot project with Vancouver and Prince George, but quite quickly spread across the province, and we were blessed in the sense that all the health authorities sponsor at least one team, and there were others that sponsored more than one team, but we ended with about 17 teams across all the province that joined this effort. And those participants were frontline, which is another important distinction because we heard today the system changes that are required and that affect somehow policy, but at the end of the day is that frontline clinician or community that is dealing with the issue. So we also needed to look at that level. So we needed to listen to the frontline providers and help them to manage those clients. Once that is, participants are selected, the launch of the collaborative started. We started in December 2010 and go through a series of learning structured sessions where all the providers come together, discuss their particular issues, bring examples of what they have succeeded or areas where they need help, and they share with the rest of the participants, and it's a very interactive process. And they also plan for their action periods that follows that learning session, where they do traditionally what is known as PDSA, which is Plan, Do, Study, Act, which is very much like a scientific method, which started by identifying a potential intervention, testing that intervention, seeing if it works, and if it works, then spreading it. And so through that same process, interactive process, during the first year, we have 3 learning sessions and 3 action periods that concluded in 2011. And then as a result of that initial process, we look at how we will be sustaining that, and with consensus from the participants, it was decided that we needed to continue that process and now transform it into what we now know as HIV Quality Improvement Network. So what are we trying to accomplish then when we started this process? We have a shared aim, and that was to improve retention in care, as I suggested. We also want to improve the HIV care and services for those individuals who were engaged with the team. And we wanted to strengthen partnerships in care. And it was surprising to us that there were some teams that were just forming, so they did not have an established team. And a good example is Northern Vancouver Island and Port Alberni, which were just coming together. And what they found is that some of the tools that they use, learned from what other teams had experienced, were useful in the way they shaped their team. But these 2 teams did not have physicians engaged with them. There was no clinicians providing care for the patients, and these teams did not have HIV positive patients. But they quickly implemented a needs assessment for clients and also a needs assessment for providers, and they essentially ended finding what was the common ground and ended establishing a very good partnership between the team, the clients, and the providers, and that's how they improve access to care. That's just an example. Now, the other question for us is how we will know that a change is an improvement. So not every change will result in improvement. So we use some shared measurements, And we have what we call 4 core measures. So we look at the date of the last primary care visit as a way to look at engagement. We also look at the HIV viral load and the antiretroviral uptake and virological control. So those 4 measures form part of the common measurement system that all the teams reported monthly. It was a struggle for many teams that did not have an electronic medical record, so they have a little bit of a struggle at the beginning. But through the process of sharing and learning, they also were able to learn from others and establish their own system for measurement. We all use the same definitions. We all use the same reporting times. An additional measure which came, although we thought about that in the beginning, but we have difficulties in using on identifying a common tool, was the patient experience with care. So we wanted to also know that if the changes that we were making were also affecting patient care. So then we look at what changes can we make that will lead to an improvement. So as I suggested, incremental system-level changes using ideas from different sources, the clinical guidelines, chronic care model, patient insights, expert ideas, colleagues. And that was a very interactive process that we certainly call the stealing and sharing of ideas. I'll skip some of these slides just for the sake of time. But these are the teams and how they were spread across the province, so Interior, Island, North, and Vancouver area. Sorry, I should have moved that out of the presentation. But these are just quick pictures of some of the teams coming together, face-to-face meetings through the learning sessions, and engaging the learning, sharing, and action planning that needed to be taking place. And in between learning sessions, as I indicated, there was the testing and measurement and implementation of their ideas. And just a few words about measurement, because it's an important difference. When you look at the results, you'll see that some of these results might be questionable, and you might be challenged from the scientific side. And I wanted to be sure that you understand that when you look at quality improvement, there's differences between improvement, accountability, and research, the way you set your measurement. When you look at an improvement, for instance, your aim is to improve care. When you look at accountability, the aim is comparison, so you have choices and reassurances that you are doing the right things, or you just manage the change. When you are looking at from the research perspective, you're looking to generate new knowledge. We were not generating new knowledge. We were implementing known information or knowledge into practice, and so on. So I'm just going to skip this slide, but it's available online for you to review. But it also gives you the different measurements and the different characteristics of the measures. So on January 31st, 2012, the collaborative transitioned into the HIV quality improvement. So we concluded that the first 12 months, we succeed on the goals that we wanted. So we increase engagement, we increase retention, we increase proportion of individuals with virological suppression, and ended showing that was what we wanted to do. But that the challenge was how we could sustain that over a period of time. So that's why we extended into the network, and the network decreased the intensity of the participation, so less learning sessions, less measurements, still doing quarterly rather than monthly measurements, and so on. So to test whether we were able to sustain the change. And we increase our peer leadership and focus on sustainability with support and direction from the response team. We assemble a response team from the same participants that guided the next steps, and some of them are here, so I hope they can comment after. But what we observe from this collaboration is that we now have an HIV registry for our clinic and know our patients, who our patients are. These are the expression of people that actually engage. While before, they have their patients, they knew them, but they didn't know that they were not showing up, or they didn't know that they were not taking antiretroviral therapy, or they didn't know that they stopped. They now knew what were happening. These are some quotes. We now have an HIV flow sheet updated to reflect guidelines. We set up a reminder system in our EMR for STI screening for HIV-positive patients. We have an interdisciplinary quality improvement team and so on. So there was really some of the positive side. And this is the data that we had, and you can actually see from the four measures that I actually indicated that a significant improvement from engagement from 67 to 90%. We set a target of 95%. In terms of the primary care visits every 4 months, actually that never reached the 90% goal, but in the midst of that, there were changes in the guidelines that some patients who are very stable are moving now towards visits every 6 months rather than every 3 to 4 months. The plasma viral load test every 4 months as another proxy for engagement at 85%. We also discovered some system issues that we're trying to work on in terms of remote areas not being able to send the plasma viral load in certain dates because there is no courier or the labs will not take it, and some issues around not enough plasma to test viral load and so on that we're trying to address. We also look at the uptake of antiretroviral therapy also going up to 96%. And maximal virological control also staying about 92%, but you can see the second half of the chart beginning on January the 12th is sustain the changes, which is what we wanted to do. So we we introduced changes and they're being sustained. And in the bottom chart, you can actually see how the proportion of teams using actually collecting and using patient feedback for the purpose of their programs. So I think I'm up now for time, so I'm going to stop here. But I want to acknowledge our funders, but also our response team, who has been very useful in terms of guiding this collaboration. Thank you.
Well, good afternoon. So thank you very much for having me here. And really, I'm here representing NeuroPIC and an entire team of people who've been involved in the collaborative and are involved in women and children's care in BC. So what I was going to do today is really just talk through a little bit of what we've learned as we've kind of gone through this journey of trying to care for a particular subpopulation of people with HIV in the province. And then I look forward to some discussion around where we might go to improve things in the future. This is still quite a stretch. So I just wanted to sort of highlight a few of the women-specific and children-specific issues, share some of our challenges and some of the approaches that we've found have worked for us, and suggest maybe that we could be a little bit more integrated in our approach across the province. So I just wanted to start with one comment on the cascade of care, in particular to focus around diagnosis. So we have ambitiously been launching extensive testing programs that are now getting out into, primary care clinics and general hospitals and all sorts of things. And so I applaud that, and obviously, as illustrated over and over again this morning, if you don't know you have HIV, there's nothing you can do to engage in helpful care. But I guess I just wanted to point out that in particular for women and youth, the new knowledge of an HIV diagnosis comes in the context of their lives. And in some cases, their lives are actually quite considerably at risk. So they're at risk for violence from partner and or extended family. They're at risk of stigma that can be quite life-altering. They're at risk of depression a wee bit more in women than men, and they certainly need to be ready. You have to be ready to connect them with tailored care. So we do run into these challenges where in a relationship situation, particularly with rapid HIV tests, where you don't really have the time to kind of sort out the situation of maybe a couple coming in or whatever, that if that woman, for example, is HIV positive and the partner is negative, that may actually be quite risky for her to find that out, and therefore navigating whether disclosure or not and so on. So I just put that out there as an issue that just needs to be considered in our programming because of the complexity of learning that new diagnosis. So then I just want to shift a little bit into sort of models of care. And I guess I'm suggesting that we really do need to have a sort of particular plan when it comes to women and children that needs to be just a little bit more tailored than to some of our other populations of primarily men with HIV. So we've been dealing with HIV since the 80s in women and children in British Columbia, obviously not to the kind of numbers you see in sub-Saharan Africa elsewhere, but certainly with the initial epidemic coming in a male population, as women and children were beginning to be diagnosed, they of course were the minority and not really the face of AIDS. And so they were often trying to seek care in clinics that were really struggling to deal with the burden of disease in men. And that has been shown to have resulted in a reluctance to engage in care, a reluctance for care providers to even test women because they presumed women wouldn't have this disease, and so a tendency for women to be diagnosed late. We, however, in BC, I think at least for the prenatal care piece, and David Patrick was very instrumental in embracing an early recommendation for prenatal screening that was the first province in the country to actually offer prenatal HIV tests. So just to sort of do a quickie overview, and I know this was addressed quite a bit this morning, but we do have a significant number of women who are HIV positive in Canada and still a significant number that are undiagnosed. About a quarter of new infections in Canada are in women, and the vast majority are reproductive age. So the layering of those reproductive health issues on top of their HIV issues is very real. We have significantly overrepresented in marginalized populations, and certainly in British Columbia, about a quarter to a third of our HIV positive women are Aboriginal, and about a third are immigrant women from primarily here in BC, Sub-Saharan Africa, in Ontario, Quebec, a bit more of Caribbean, but certainly with many integration, immigration issues, language issues, and so on that are associated with that. And obviously, as been illustrated before, we're seeing an increase in the prairies, and we are also seeing that increase in particular in young women and in young women who are pregnant. So our prairie colleagues are calling us a lot these days in a bit of a panic because it's really a problem for them. And this is really, I think, very interesting and illustrative that the red bars or pink bars, what color are they red, in women are just showing that in terms of new HIV positive tests, women are actually a significant proportion, particularly in certain sub-age groups. This is PHAC data. With the vast majority heterosexual contact, but certainly in substance use, injection drug use being a significant problem for risk of acquisition for women. So I just wanted to talk, I mean, many of you are really quite familiar with Oak Tree Clinic, but I just wanted to talk a little bit about our model and share that model of care for you. So this is a clinic that's physically based at the BC Women's Hospital. It's a women and family clinic, and it started in 1994. And it really started out of a belief that in the context of the predominantly male epidemic, it was really important to provide a space that was women-centered, that was children-friendly, that actually was sort of really devoted and focused on this particular population with different needs than the needs of many of the men. And I think particularly when you think back in 1994, really pretty novel model of very much multidisciplinary care, where we actually, instead of having women, which across North America and many parts of the world still traipse to an HIV care provider, an OBGYN, a primary care provider, then a pediatrician for their kid, and then maybe psychiatrist or whatever else they may need, we actually said, okay, clinicians, inconvenience yourself and come to the clinic together and work across the hall and with each other and actually do it in the one-stop shop. And I think that model of care, as awkward as it actually is for the clinicians, is actually women-centric and family-centric. And so they can come, and we run around like headless chickens trying to make it all work, which is actually kind of our job, as I would suggest. So we also have nursing, pharmacy, social work, dietitian, nurse practitioner, counselor, and psychiatry in-house with us on various days to really support that integrated model of care. So the number of times that they have to go for an external appointment, other than back in their community, perhaps to primary care providers, is really rare. So if they're coming for subspecialty consultative care, it's pretty much a one-stop. We've seen many, many women over 15 years, 25,000 patient visits, but our model really is to try and not just be a local Vancouver direct care clinic, but to try and provide a provincial role for consultation. Sometimes in cases we'll do just once-off consults. We'll do that sometimes in prenatal care, where people live very remote, but we'll sort of see them, try and kind of put together a plan, and then have them go back to their community, and then deal long distance. We often do phone consults, and just trying to suggest around particularly reproductive care and pediatric care that is particularly specialized. We've been very involved in guideline development, education, and we have quite a large research program that is very much in partnership with people across Canada and internationally. This is the kind of distribution of the patients we see, which is of course very different from most other HIV clinics. So we obviously have our pediatric population, which is pretty much 50-50 girls and boys, but then our young adult and older population, which is predominantly women, although we do see some men, but our mandate is certainly to focus on women. And what you'll see with the age range there is we've also got, and I'll talk a little bit more about this, our youngsters transitioning to adolescent and young adulthood and all of the challenges associated with that. They're HIV-exposed, uninfected kids. So they're still, sort of from a health delivery perspective, sorry, they're still our patients, but they're not HIV positive. Thank you for pointing that out. No, we don't have this huge number of infants that are HIV positive. And primarily they're from Vancouver Coastal and Fraser, but we do see individuals from across the province for consults. So, I mean, maybe I'm sort of talking to or speaking to the converted, but we do actually believe that it is appropriate to consider that each subpopulation with their own needs need some special considerations, and I think women do need special considerations. And as I've sort of alluded to before, there are definitely significant barriers to care for many of our women. Many of them are living in circumstances of violence, and actually disclosing HIV and seeking HIV care may actually be at risk for them. They're very frequently impoverished. They live geographically far away, and transportation is a problem. Particularly our immigrant women with language barriers and cultural barriers. Once we get them in and engage them, it's often fine, but initially engaging is challenging. And mothering is a big issue. These women are caring for often large extended families. They're the primary head of the household in terms of coordination and delivery of care. And the last thing that they want to bother about is actually taking care of themselves. So in fact, often the visits with their children will be able to pull them in for adult care, because they'll traipse in and take whatever transportation to get their child care, but they won't actually do it for their own personal care. We also find pregnancy and reproductive health is actually another engagement and care hook, where in fact they won't come in for themselves, but when they're pregnant, they'll come in for their infant. In fact, actually, we had a gal who was 10 years HIV positive, 0 antiretroviral treatment, CD4, if I recall, about 190, drops in at 33 weeks gestation with 0 prenatal care, and it was just scramble, get out, pull in the troops, and we actually ended up, at her request, admitting her to hospital. She went into labor last night with a suppressed viral load, and I think should be delivered by now. So. But that's the kind of thing that, and I'm really, really hopeful that the double positive is that she will engage in care herself, which will be our effort in the postpartum period. We have some other gender-specific issues that are associated with the aging phenomenon. So the benefit of living with HIV is that you're living longer now. The problem is then you're also aging and aging in an accelerated way. And for women, we have some specific issues around aging that we need to deal with in terms of more problems with osteoporosis, perhaps some unique issues with neurocognitive, some unique cancers, and menopause, although I think I have that another slide. The reproductive health piece is also important, and we have to think about the fact that primarily these women, if they're sexually active, have to deal with either prevention of pregnancy or desire for pregnancy and how to do that safely and appropriately. And in the context of HIV, that's a wee bit more complex. Safe sex is not necessarily easy to navigate and to be able to control if there's power disparities in relationships that they're in. And pregnancy desires are something that was often not asked in the past, so women felt they couldn't reveal that they wanted to become pregnant as an HIV-positive person. I believe that is dramatically changing, but certainly in our survey studies across the country in collaboration with colleagues in Ontario, we do find there's still a significant proportion of HIV-positive women in Canada who seek care under circumstances where they believe they can't reveal pregnancy desires to their care provider because they believe it's considered inappropriate for them. They don't all understand, and many primary care providers do not understand that it is possible to prevent mother-to-child transmission. I had to put these two slides in. You're going to have to forgive me. But I really do have to say, as much as Julio is really excited about treatment as prevention actually originated back with this study. So there was a study that was devised in the early 90s that was a randomized controlled trial of AZT versus placebo for pregnant women, both antenatal, intrapartum, and postpartum. And in fact, in February of 1994, showed a statistically significant, dramatic decrease in transmission of HIV from mother to infant. And this really is the beginning of treatment as prevention. And I recognize, of course, that the translation of this into the adult and into the general population is recent, but we have been practicing treatment as prevention for a very long time. However, it is not, again, as Julio suggested, like that to prevent transmission. It's actually quite complicated, and we've been seeing hundreds of mother-infant pairs since 1987, and had almost 400 live births in our. This is actually about a year and a half old data, and we've been very fortunate. And I hate to say this without being able to touch wood. This is probably plastic, but we have not had an HIV transmission in women engaged in care. But that has been because of an enormous amount of effort for each and every pregnancy by a multidisciplinary team in collaboration with regional and primary care providers around this province that work like dogs through each one of these pregnancies to make sure this woman, in her particular circumstance, can actually engage in therapy. And these are high-risk pregnancies. They have higher risk of preterm birth, about twofold the population. They have higher risk of growth restriction. They have now, more recently, we're seeing higher risk of preeclampsia, a lot of placental insufficiency. So there's many things going on. So yes, we've been successful, but it is not because we just kind of write a script and say away you go and do your prenatal visits. It's pretty intensive. The other piece that I just wanted to mention, which was a bit of a shock to us, is that what also informs treatment as prevention is that when we've had these pregnant women who are highly motivated to take their antiretrovirals and are really doing very well with it, when we look at their viral load at delivery, 9% of them are actually positive when they were suppressed earlier in pregnancy. So we are still giving IV AZT and AZT to babies because we're getting a bit of virologic blip at that time. We do have a distributed model of intrapartum care. Our women deliver all over the province, and there's 27 maternity units in this province that have kits with instructions with intravenous AZT and liquid form AZT for baby, and in collaboration with the Center of Excellence, particularly their pharmacy side, we update these and distribute these and pull in data from this. And we've done so since 2000. Just this last year, we did a revamp based on evidence around changing dosing and slightly changing the guidelines. So it's a little bit updated, but this is really just an illustration that HIV positive women deliver in many, many units across the province. I do want to just make a point around the value of surveillance. We really are trying to ensure that even though people feel comfortable with HIV care in some particular site in their province for prenatal care, we really do want to know about these women. We want to know what they're on, what the outcomes are, because only with the kind of numbers we have, only with a provincial centralized surveillance approach can we see flags. And we were one of the earliest centers. There was 5 of us across the world that started to see serious complications with nevirapine in pregnancy. We were very fortunate we didn't have any deaths, although colleagues around the world did. And that's what led to the black box warning around nevirapine in pregnancy. We had a 10% life-threatening toxicity. And so the only way we can start to understand these trends that happen in isolated small cases is by getting that population level data. I'm sorry, I'm going to go over time a little bit, but I'll hurry along here. The other piece I just want to flag is really, really new information that we're trying to understand and work on as part of our research, is that it looks like HIV-exposed uninfected infants may have some immunologic deficiencies, particularly in the first year of life, that seem to be flagging for increased infectious morbidity, for ordinary pneumonias and other things. So it was first described in South Africa and Belgium, and we're looking at our data in BC. It's a little bit equivocal right now, but it's just highlighting that this population you were talking about, Rich, that we follow, which are our kids that are PCR negative for HIV, do require more intensive surveillance in terms of their general health outcomes, and we really need to understand that better. Who are these children? Well, we do continue to follow HIV-infected children, some of them just simply getting older from the early perinatal transmissions, but we still get a number of immigrant children coming from families will come, and then we'll get a number of new kids from other parts of the world. We have a number of perinatally infected kids growing up with a mean age of about 14 years right now, and we've actually got 3 young women who've gone on to have 4 pregnancies, one currently, that are teenage and young adults, and that provides a whole other challenge. 17-year-olds that are pregnant are challenging enough, but with lifelong HIV, it's a little bit of an added twist. So we're collaborating with other centers around North America on a pooled data set to understand unique complications for this population. We are transitioning our youth into adult care, and again, the advantages of our integrated model is they can slowly transition as they need. Sometimes they need gynecologic care as a teenager. Sometimes they're ready to move to adult care earlier, later, and so we're trying to do that appropriately for them. What have we done in terms of the Stop AIDS enhancements? We aren't a big part of the Stop AIDS sort of funding model, but we've been able to participate as best we can in the collaborative. A couple of particular things we've got involved with is outreach to Alouette, the women's correctional facility that is actually, I think, upgrading in terms of the level of security on it, and therefore a larger facility for women, but a significant problem with undiagnosed HIV or HIV positive not in care women there, and obviously particularly hard to engage population. Partnering more with Northern Health and looking really at very intensive outreach in our women that we know have CD4s less than 200, and Rich, who's the expert in this, has been working with us on a pilot study to use cell phones and text messaging, and we're determining, it looks at least on our preliminary data, that text messaging on how people are doing with their meds is actually becoming quite an effective tool in engaging our most challenging high-risk groups in care. So we've learned from Stop AIDS, and we continue to try to learn in terms of collaboration, teamwork, and it's always small steps. So just to conclude, What we're hoping is to enhance an integrated network. We recognize it's inappropriate for women and kids to all traipse down to Vancouver and see us in our clinic, nor do we have the capacity, but we hope that we can try and share some of the things that we learn from our higher volume that we see of women. We recognize women are often in communities in relatively small numbers of HIV populations, don't necessarily want to talk to each other. Sometimes they do, sometimes they don't. And we can provide long-distance support for women and children as best we can. So thank you very much. And I'll stop, and we're going to do the questions at the end. Okay, great. Thank you.
Okay, thank you very much for the opportunity to participate in this. And I will look forward to the discussions at the end, so hopefully we move along with some time for that. So I'll go through some slides again. I'm doing some updates, focusing a bit more on recent innovations in best practices. There's of course a lot of very long-standing best practices that evolve, and a bit from our BC CDC perspective. But I know there's a lot of incredible work going on throughout the province, and a lot of it, I think, as Julio's mentioned today, and Rolando mentioned, and actually everyone's mentioning, which is great, the cascade of care and all the various points of interaction to improve everything from engaging at-risk populations into getting diagnosed and engaging in care and treatment and staying on that care and treatment for most effective outcomes. And that was actually, even there's a publication with Dr. Mark Hall and Julio Montana recently that diagram came from. So I'm going to talk about, well, there's first prevention first. Now, it's not, primary prevention isn't technically a part of the STOP program, but obviously it's an important ongoing level of intervention that we work on. So education, risk reduction, harm reduction, with sex and IDU being the major transmission ways, pre-exposure prophylaxis and NPEP are all sort of primary, or NPEP you may or may not call primary prevention. I'm going to talk about who is infected and where might we find them in terms of best practices, but innovations. A major step, of course, is getting tested. That's the entry into the best entry into the cascade towards engagement in care and treatment and secondary prevention. What test for who and where, and there's some innovations and new things that have happened over the period of the STOP program that we'll talk about. And then, of course, engagement into care, linkage into care and treatment in an ongoing, sustainable way is really key to the success of the ongoing program. Prevention first. There's all those things I already mentioned. A lot of them have been through hard work, through many programs throughout the province, through many years, and have been very successful. And we saw rates of injection drug use-related HIV transmission, or at least with that group, come down dramatically. Lots of harm reduction benefits, education, cultural appropriateness is, of course, an absolute key to primary prevention. And I'll just highlight a bit the CHIMAMUC program from CDC, but they'll be talking a bit in a workshop following this. Lots of outreach effort throughout the province. And then some of the emerging things are online resources. And I think for primary prevention and education, one of the recent innovations or improvements is the Smart Sex Resource Program, which is really intended both for general public sexual health and risk reduction, and there's blogs that are interesting for care providers. And Mark Gilbert and Devin, etc. have really been working hard on this program, which has already been launched. So please do look at that site. Lots of great information on primary prevention. I get to follow Mark's incredibly detailed and fascinating update on the epidemiology of HIV in the province. But just HIV testing trends pre and post STOP, which is something I condensed but Mark also showed, is you see that testing volumes in Vancouver and the Prince George went up. And it doesn't look like the diagnosis went down, but if you look at testing volumes went up, but new diagnosis plateaued. So hopefully that means that's an overlap of increasing detection while decreasing incidence gives you a sort of a plateau. So those are both, I think, good things to show, which is compared with other health delivery service areas where you see testing hadn't increased as much. Rates are decreasing, but maybe if we increase the testing in those, we may actually detect and link more people into care as well. Who is infected is a key. It's still, there's many people, and anybody who's had sex, anybody who's shared blood through needles or other is at risk. But the primary people getting infected, the new diagnosis in BC remains. The injection drug use as a risk has reduced quite substantially. Not all the way there yet, but heterosexual and then the higher rates of MSM are still holding steady. So there's that's really the highest risk group contributing to the ongoing infection and diagnosis in the province. So what are some innovations about getting tested? There's primary clinic-based testing, as you know, hospital-based testing and routine testing programs, which you've heard about elsewhere. Public health, sexual health, STI clinics, outreach testing. A couple of the newer, more recent things are point of care, and then an emerging one, which we are hoping to see as soon as possible. And I know Mark and their team have been working very well. I think it's going to be an absolute breakthrough in access to testing is online testing, and that'll be rolling out over the course of this year in the pilot form to start with, and more knocking on plastic and wood. So this program, online testing, is really going to allow people to self-determine their risk, get information, be able to download requisitions and get the appropriate results and follow up. Which we're quite looking forward to, and may access new groups of people who don't access health services at other points of entry. Innovations in HIV tests. There's a lot of HIV tests available. With going into all the details, the standard test is the HIV IgG antibody test. There are new tests that are better at detecting it earlier. So the big ones. One is so the pooled NAT, which Mark talked about. I'll go into a bit. The other is point of care. Point of care is actually a standard test, but rather than having to send the blood to the lab and come back for the results after a turnaround period, the results are available within a few minutes. Why is acute HIV in testing important? And this is, to me, I think, again, one of the most critical factors for HIV control in the province and anywhere. It's high viral load equals high probability of transmission. Earlier diagnosis and potential for behavior change. If you can diagnose it early, acute is early by definition. So earlier diagnosis, less time for transmission, also the highest rates of transmission at that time. They're also indicative of high degree sexual networks. Those who are at the highest risk tend to test more frequently, and those that are getting acute diagnosis tend to be in higher risk sexual networks. So intervening in knowledge at that time is going to be absolutely one of the most impactful things we can do in reducing onward transmission. Pooled NAT testing simply is just taking, because it's an expensive test, taking a bunch of people's bloods together, testing, and if one of them's positive, then breaking it down to see which one is positive. And then so it's just an efficient means of doing an expensive test, which is an RNA test, a PCR test, basically looking for the virus itself. So the window period is much, much shorter than waiting for antibodies to be determined or to be generated from a standard test. And also thanks from Dr. Gilbert for the graph. Since introducing pooled NAT testing in British Columbia, the percentage and proportion of people who are diagnosed with acute infection has gone up substantially. So I'd say it's had a major impact. 34 out of 155, so 21% were of HIV positive diagnoses were acute infection, which is an increase from 8.7% prior to the introduction of pooled NAT. This is the real key, though, and we see this all the time in the high-risk clinics. People have negative regular HIV tests, so third-generation HIV tests, but positive on the pooled NAT. That means the difference is of going home thinking they have a negative HIV test from going home knowing they have not only a positive test, but a positive test at the time when they're absolutely most infectious. So 46% of men at 6 high-risk clinics with acute HIV infection would have received negative results before the introduction of pooled NAT. And again, they're at the highest risk of transmission. So the estimated 1 to 3 new infections were averted in the year after acute diagnosis, and the savings are in many millions of dollars. When you avert HIV transmission, it's a major health saving to people and to the system. And of course, that was a very large collaborative team effort that allowed for that program. Innovations point of care, this is just a picture of the point of care for anyone who, you've probably all seen it in this room. It's a 1, 2, 3-step thing. It only takes about a minute to get a result at the bedside. And in the province, 33,000 have been distributed. About 17,000 different tests have been, point of care tests done at 62 sites, 7 of First Nation sites, and quite a number, 173 health professionals trained in performing this test. What its role will be in British Columbia, or should be, it has limitations. It's not it's a rapid test in that we get a rapid result, but it doesn't shorten the window period. It's the standard test, so it has that limitation, and it also requires confirmatory testing, but it certainly will, I'll leave others to speak to the role that it may play going forward. So HIV diagnosis being a rate-limiting step in the cascade is really important and in line with the STOP goals for individual and public health benefit. Success of low-threshold testing, the Butte Street and HIM Clinic, which has expanded their hours and services over the course of STOP, really about being lesbian, gay, bisexual, transsexual friendly clinics, have really meant low-threshold places where people can go and safely feel that they can get an HIV test and other STI testing. It's been very effective in that out of all the infections in the province, actually, 54 diagnosed in 2011 and 42 in 2012. So about 18% of all new infections in the province have been diagnosed at these 2 relatively small clinics of fairly high volume, very low threshold testing. So a big lesson to learn here, I think, is just by being a friendly, safe site for testing of the most at-risk groups is highly effective. And the other thing is that many of these, almost 20%, were acute or early infections, suggesting that by catching these 20% of the province early, we're also preventing this long period of potential onward transmission. It does come with challenges, and I think the STOP program really helped identify this major challenge with this model is that people come in, they aren't required to use ID, they use fake names. We test a lot of Mickey Mouse and George Bush. I shouldn't probably say that, erase. So we test, but which is very fine. It's a very, very, very effective mechanism because people feel safe. They know that it's confidential, and we diagnose, or they, I would say, a lot of people are diagnosed with early and HIV infection. The challenge for us as health workers is we don't know where Mickey Mouse is followed up and if they're followed up and so on. So that's been one of our real challenges to work on within the STOP program, which I think we've worked with closely with Vancouver Coastal and others to enhance linkage to care ideas. So one of those actually innovations, and we work with Rolando as well, is the idea of can we do CD4s and viral load at the testing site while people are in that comfort zone of the place where they went to get tested and have a positive test. So we introduced an immediate HIV staging pilot program at these sites where we offer CD4s and viral load at the time of their positive point of care or positive HIV test result. We offer that immediately, hopefully with a transition in doing that with nominal care, because as you know, HIV care and treatment is free in the province, but people do have to use their own names and real names for that. So we felt that this has been very successful. It's hard to know because we went from not knowing where they followed up to now knowing that they're following up. But the uptake has been quite good. 20 offered, mostly MSM. 60% had CD4s and viral loads done. of those that were offered it had them done immediately, and 70% at 1 month had shown they had linked to care. So I think we're making some improvements there, but time will tell, I think, the success of this program. But really our hypothesis is that by knowing more, knowing not just that you have an HIV diagnosis and one day you're going to need to get care and treatment, knowing their CD4 count and knowing their viral load and having those discussions as a more complete package early is more of an incentive into care, and also just that knowledge is more engaging in care. Another innovation in engagement in care, which is something we've been adopting, and Dr. Money mentioned with the Oak Tree Clinic as a pilot. So when I was living and working in Kenya doing HIV research, we came up with a cell phone program where we really do a very simple model of using text messages to check in on patients weekly, and this came up from the multidisciplinary team. So all we said there was Mambo, which is how are you, and at the Oak Tree Clinic they're sending how are you or are you okay? And they respond either they're fine or they're not fine, and if they're not fine, the nurse calls them back. So very, very simple, very non-intrusive, respects privacy, doesn't say anything about HIV, doesn't say anything about clinics. In the Kenya, we did a randomized trial which showed that they were more likely to be adherent to their medications with this text messaging support, but also even more likely, almost 20% more likely to have a suppressed viral load at the end of 1 year. So an objective outcome. And we're doing a very exciting pilot, which is now complete, and we're analyzing the qualitative data, and the team there has been successful at securing a bit more funding, where we do 5 by 5, which is 5 youth, 5 mature, 5 remote, 5 English as a second language, and 5 mostly addicted and non-suppressed patients. I'll just let you read. This is the interactive part. If you just read some of the... Sorry about that. Yeah. 5 minutes? Okay. So if you'll just actually read, these are some of the participants from the qualitative interviews, just a few quotes, but I'll give you a minute to read. And the fascinating thing to me is that it's not just about reminders, and our research in Kenya supported that it's really about that linkage to care and support and frequency of contact that's providing the benefit more than just pure reminders. And we've actually been working with the China CDC, who've been adopting some of this work for their national program to try and work to engage people in care there as well as Kenya and some sites in the US and South America. And this is another one, if you just read, this is an actual text message, and I think Karen is here, actually, the nurses, but just again, adherence is not just about did you remember to take your medications. Adherence is very complex. And I think just that really, so the cell phones are not about us telling them what to do, but really about providing an avenue of engagement and care and linkage to all these multidisciplinary services that we've been hearing about. And in fact, now text messaging has made its way into international guidelines for engagement in care. And it's something we're working on to try and develop from that model to scale up throughout British Columbia, and working with a few partners, and we've developed some technology and have some support from Grand Challenges Canada and Bristol Myers Squibb to start to develop a platform for scale up. So I'll just summarize quickly. I think I'm at the end of the time. Best practices and innovation. There's many. I've only touched on very few. Prevention, primary prevention, still very important. Reaching people before they even get tested, or and with education on risk and harm reduction, reaching people for testing, low threshold testing, friendly testing to people at risk, places where they feel safe, and getting tested. I think a lot to learn from that. Getting tested, targeted 4th generation, and NAT is something that's being looked at going forward. Anonymous testing, I think it may be a new pilot coming, as well as ways for people to protect their identity, has some of the similar issues that are being worked around with how do you then link to care. and engagement in care, support, and mHealth being some emerging areas. So we'll take us back to the cascade, and thank you.
Thank you all for your presentations. We've got 20 minutes now for questions, for conversation. We've got a microphone here, or whatever you guys would like to do. There's no way that nobody has a question. It's just not possible. Do you want to come up to the mic, Sam?
Sure.
Thank you.
Just a quick question about the future of testing. So when we spoke about the online testing, and I take it just from the screen, you print the rec off, and you go into a lab, and they test, and then your results probably get, I would assume, sent to your doctor or a site that you can go and get those results. Sounds great. Question I have on that is just the education behind it. Is it just a little online survey you fill out to make sure you're not at risk, and where we're looking at the pre-test guidelines? And then also an experience I had is when I have tested for HIV, I have no problems going to my family provider to get a rec, but where I run into the issue is at the lab. And I've always been kind of made to feel like I'm the god-awful, cheating, scumbag husband whenever I'm in the lab. So now I just draw my own blood when I get a test. It's just easier that way, and I just don't have to deal with that. So I was wondering if there's how are we kind of educating the labs around town that do these draws? And then the other kind of looking into the future, is there any conversations that are looking at when home-based testing is coming? So it's when the point-of-care test is right next to the pregnancy test in the pharmacy, and you can go in and pick it up.
Okay, I'll speak to those partly by enhancing our participation by passing this off to Mark Gilbert, who's in the audience. Who's in the audience. But Mark and his team have really been leading the online testing pilot, so I'll let him speak to that. And in terms of the last question though about home-based testing and buying a test at the drugstore counter. Not yet available here, but already available just a few miles south of here in the States. So something we really have to be looking at and aware of, and aware that clients actually don't have to go very far, so maybe they are doing that. I don't know about the plans, though, for when it'll be introduced in BC. But Mark on the...
Sure. So in terms of the online testing, it's been a program we've been working on for quite some time. It's been quite a challenging program to try to develop. We have been taking very seriously the considerations around education and pre- and post-test counseling, looking at our current best practices, how does that translate to an online environment, looking at how you elicit informed consent online, and have been really trying to think about that as very carefully as we can. The pilot we were hoping to launch, again, sort of knocking on wood, it's been a bit of a challenging process this year, is sort of centered in 2 clinics at BC-CDC as well as a targeted promotion to gay men, and we have a CHR study that's really carefully evaluating the impacts of it, so looking at knowledge gain through the process and that kind of thing as well. So that'll really help us understand the role that it plays. We are, in terms of working with like the private labs, and I can hear your point there, and we're just now beginning to be talking with them about at least how clients will engage at that point around the online testing. But it is something I don't think we've had a lot of discussion sort of as a province around. So while I'm here, I am going to ask a question. And this one's for Deborah. I guess, Deborah, I've been struck recently by some reports of increased HIV incidence amongst, or maybe just now detected high rates of incidence amongst transgender women in other parts of North America. So I'm wondering, I know that in our surveillance data we have very poor data that allows us to identify cases amongst transgender women. I'm wondering what your experience has been at Oak Tree with that marginalized population.
I suspect we probably aren't aware of the total burden of disease in transgender women, but we do have a handful of individuals, a small number, that attend Oak Tree, and I think it's again an example of very complex personal life challenges in coming to grips often with revealing where they're at in their sort of journey to transgender. Often that's not is happening as people are getting older and coming to terms with it. So that gets layered into the HIV care issue. So I'm just thinking of one particular woman, well, individual now, who really, he disappeared from care for a while and then sort of re-engaged. And I think it was really the challenges around that interfered with engagement in HIV care for a stretch. We don't really have really good data on where those individuals are going for care in the province. I mean, I suspect some of the downtown clinics are more accepting, but I think people are probably all over the place in small groups. Yeah.
If I might add to what just Deb said, because in my role at the HIV clinic at St. Paul's, we also tend to see some of these patients from both sides in terms of transgender male to female and female to male. And it's certainly a challenge, and I certainly agree that a lot has to do with the ongoing mental health issues, accepting and some unresolved issues, particularly around surgeries that are not being funded or being delayed for them to fully become transgender. And I think that's where a lot of the challenges are. And certainly in Vancouver Coastal, as you probably are aware, there's a transgender program that has been trying to move out of a particular clinic, but is still very much centralized in the Three Bridges clinic that tends to see a larger number.
Thank you. Rolando, I just had a question regarding the collaborative. It's been such an excellent experience to be a part of it. I think just seeing the 17 teams energized and then go from highs and lows to, being QI'd out, so to speak, and then engaging. Oh, hi. My name's Denise Thomas. I'm working with First Nations Inuit Health Branch, soon to be First Nations Health Authority, and I'm a nurse CDC coordinator. And I just, my question regarding the collaborative model has a 13-month expiry date, so to speak. And I'm just wondering, in terms of the rollout of the STOP program, will there be a cycle that will bring new teams in and phase new teams out? And just in terms of what that would look like, because we have more experienced teams now that can almost mentor the other teams. And then my second question is regarding partnerships in care. Will the collaborative be measuring their ability to partner and have targeted partners, maybe like corrections and other partners? Thank you.
Yeah. Thank you for the question. I almost feel that Sam and others can also be interactive and answer some of these questions, but I'll try. This was an initial pilot project that started by being a 12-month kind of a project and extended to another almost 12 months, a second year, and transitioned from that very heavily focused on quality improvement and say, if you want it, expert-driven to a more peer-driven in terms of transitioning into the HIV Quality Improvement Network, which, if you were to look at what has happened with other similar organizations acting similar to that HIV Quality Improvement Network, will continue regardless of what we do. They are already very strong. They have created that network. They know each other. They know how to connect. So I'm hopeful that will continue. Certainly, the Center for Excellence is committed already to continue supporting the Quality Improvement Network. It is now an issue also of ensuring that the health authorities also supports their own teams. In regards to new teams, we are in the process of reviewing the existing gaps, and we will do that in conjunction with the health authorities, with the current participating teams as represented by the response team, which is a group of peers, providers from that team, and the CFE, in order to identify a topic that will be of interest and relevance for the health authorities. It will still require that the health authorities identify their teams and support them, while the Center for Excellence continues to be committed to providing the infrastructure. Regarding to partnerships, that's exactly what we tried to do at the beginning in terms of the first wave of the collaborative, and we focus in part not so much on that larger kind of partnership, but local partnerships between different local providers that not necessarily were talking to each other, hospital or acute care with community care, social workers working for the Ministry of Social Services, and so on. So that kind of partnership was taking place. Teams, as I explained before, the one from the Northern Vancouver Island, which did not have any partnership with physicians, now they have half of the physicians in the area being partnered with them. So that's, it's a good improvement. Now, as we move forward, we will have to set a new set of focus in terms of the collaborative, new goals and new measurements, and that might be one of them.
Are there individual measurements, or are there measurements,
Or Rolando can keep
I can talk about it, it's okay. I'm Heather McDonald, I'm a doc from Outreach, I work at Outreach Urban Health and Interior Health, and I've been involved in the collaborative in Kelowna. But I'm wondering about measurables for the collaborative for health authorities as a whole, rather than individual teams. Have there been anything set for that?
Well, I think that's the role of the new strategic plan that we have, the road to hope, because that will be setting the high level kind of strategic directions that we will need to take. If you look at what we have tried to do with the collaborative, is to work with the front line, to look at what they need to do every day, and certainly align it as much as possible with the larger kind of strategic direction. So when we went out, we focused very much on suppressed viral load, for instance. And if you look at the cascade of care, which is very much to the right side of the cascade, we wanted to increase that proportion of individuals who were already suppressed. That will be very much in tune with the overall strategy. Now, what we did not want to do is burden the teams, at least all the teams, with lots of measures. So we wanted to see that every team were looking at their, say, the rate of suppression, and they need to discover why is that they are not reaching the goal that they are supposed to be reaching. Why is that there is still a proportion of individuals who are still detectable in terms of their viral load. And because every region is different, every area is different, they needed to try their own strategies to overcome those gaps in care, and so therefore they need to set their own message, their own measurements. So some teams, in addition to that measure, start looking at housing, looking at food support, access to food, and access to or adherence, for instance, as alternative measures that will help them to reach that goal. So I think it's interconnected.
Wondering more about like doing measures for numbers of HIV tests for a health authority or community viral loads or sort of bigger picture things. Is that anything that's going to be incorporated in?
Again, maybe Gina might want to answer that, because it goes back to the strategic direction, but it's also Julio briefly presented that today, and he presented the cascade of care, which will be the main kind of strategic measures that will be. And it can be actually break down by health authority and even by health service delivery areas.
There's sort of two pieces of evaluation with the pilot, and will be ongoing with the provincial program. There's a provincial, that the CFE has been leading, a provincial evaluation at population level outcomes. But in addition, the pilot health authorities have done their own evaluation of their own region, and that they're looking quite closely at how their activities have driven the drivers, for the overall provincial program. So there's actually a workshop on that tomorrow, and that'll be addressing sort of some of the more regional monitoring and evaluation stuff, in addition to what the provincial overall evaluation is. But it all needs to be linked. We found something, just about a year and a bit into the pilot, it became very clear that the different levels of evaluation were not necessarily aligned. And not in a bad way, but it was just that some people weren't chatting. And we sort of came to the conclusion that you really needed to get all of those people at the same table so that you're able to look at all the different things that would eventually feed into an overall evaluation. So I would encourage you to go to the workshop tomorrow.
And I'm not sure I'm going to be in that workshop, but I would like to stress the fact that it's a true partnership between your public health and your clinical side of their activities.
We have some public health people here, but I think that
very important.
And also just we're hoping to use some of the money for an epidemiologist, and so I think it's just trying to figure out where to put, where to look at what testing measures to look at, not just the ones that the collaborative brought forward previously, but just sort of more as a health authority as a whole.
Yeah, and as Gina suggested, you might want to also look at online. The VCH has a very comprehensive report on their measures, which are expanded measures. The collaborative were very simple, oriented to that clinical team, not to the health authority.
Any other questions? I have one that I could post it quickly, that I could post it maybe to Mark.
Yeah.
Sure.
So I don't talk into Mark Bigham. Question for you, Deb. The prenatal program's been a fabulous success, hasn't it? Would you say so? And we know that most of the HIV in women involves women of reproductive age. And we know that women, much more than men, are more likely to see a doctor anyways. Is there an opportunity here to try and expand the access or scope of HIV testing to involve just not prenatal women, but basically women of reproductive age? Not waiting for them to get pregnant, in other words?
Well, I would totally support that. I think it's really more kind of programmatic challenges and so on, but it could well be a key piece of the next phase of Stop AIDS, where when women engage for contraceptive care, ideally preconception counseling, although sadly that happens less than it could, abortion care, other things that are in that reproductive time, every one of those time points, routine pap smears, whatever, that those are engagement moments that could involve HIV testing or offering of HIV testing. The other piece where I thought you were going to go, actually, that we've been talking about is particularly in communities and in populations where engagement in healthcare is a barrier for whatever reason. Pregnancy does tend to overcome that barrier, and for the most part, even the most marginalized people will end up coming in for some version of prenatal care. But what we could do with that is actually use that woman to test the family and the people around her as a group. So, you know, she'll often have a partner and or other children and or other people in her household. So that is another engagement possibility. We haven't been routinely testing partners, and that's, I think, a missed opportunity to test men.
I think we've got time for one more question. Go ahead, Sam.
So just this whole prenatal program, it's just a story I have to tell. So I work at Central Ontario Native Health in Prince George, and in the last 2 years we've had 3 babies born to HIV-positive mums. One of the mums has had 2 babies. So the story is essentially collaboration is great, and working with Oaktree and working with partners is fantastic, but it takes a lot of work and it takes a lot of follow-up, and it also gets confusing at times. So our first baby, since I've been at Native Health, that was born to an HIV-positive mum. This mum was also on methadone. So baby was born into the NICU for a while, and then from NICU went to PEDS. And this mum had engaged in prenatal care in Prince George with our prenatal team, and had also engaged quite a bit with Oaktree. What had happened is there were so many people involved in baby's care, or in mom's care and in baby's care, that I don't think, well, I know baby got left behind. So this baby went the first year of her life without being tested again at all. She had had assessments, but no one had tested her, so we largely dropped the ball. And we were kind of in a meeting one day, and we kind of realized, well, hey, like, when's she getting tested? And we looked, and she hadn't. So that generated us to think, you know, how did she fall through the cracks of all this attention that was paid to her? How did we miss out on this? And it was largely because I think there were so many people involved, we didn't know who took the lead. And then from that point on, with her second child and with another mom that's had them, there's been a much better communication with Oaktree and with the PEDS team, the HIV specialists, and everyone involved in both parties, that we haven't let that happen. But it was a big scare for us. And so it was just kind of like, collaboration is great, but you kind of also have to have a point person on that collaboration when you're working with the client, especially when you have great kind of geographical distances and those times. And okay, I saw so-and-so last week at Oak Tree, and now I'm seeing Dr. Homore this week, but maybe that referral letter hasn't got back up, that consult letter hasn't got back up. So it's just one of those lessons that we learned in a very scary way of not following up.
So sorry, just for 1 minute. Thank you very much for sharing that. And I guess what I would put back is we would really love to hear from various regions as to how we can best help. Just in terms of the pregnancies, every single pregnancy we know about, regardless of whether we see them or where they are, we actually track them and talk about them weekly. And we're like, oh my God, we still don't have blood work on so-and-so, and what's going on? And so we actually are, and because that's kind of what we do for a living, we have a little bit of probably more time to do that. But if there's any way that we can be helpful, and if you tell us in what way, we're more than happy to change and to do things differently, because we know that these are more uncommon events in many communities than it is, for us in a centralized referral clinic.
Well, I'd just like to thank all three of our presenters today and everybody for your great questions.